Welcome to Last Minute Lecture. This free chapter overview is designed to help students review and understand key concepts. These summaries supplement, not replace, the original textbook and may not be redistributed or resold. For complete coverage, always consult the official text. Welcome back to the deep dive. Today, we're wading into some pretty deep waters. Or actually, maybe I should say deep fluids.
Oh, please don't say fluids.
I have to.
Okay.
Because today we are tackling an absolute titan of pathology. We are breaking down Chapter 20, the kidney. And I want to start with a quote that was, well, it was right there in the source text. Because it is essentially the classiest way I have ever heard anyone describe going to the bathroom.
I have a very strong feeling I know which one you picked.
It's from the Danish author Isak Dinesen. She wrote, "What is a human but an ingenious machine designed to turn with infinite artfulness the red wine of Shiraz into urine?"
It is poetic. Anatomically speaking, though, it's a bit of an undersell.
How so?
Well, the text points out that while the poetry is nice, the physiological reality is even more staggering. Your kidneys are converting something like 1,700 liters of blood every single day into just about 1 liter of urine.
Wow.
Yeah. It's not just a filter. It's a high-precision chemical engineering plant. It regulates your blood pressure, your red blood cell count, your bone density.
Your pH balance, right.
Exactly.
Well,
all while filtering out toxins.
1,700 liters. That is, I mean, that's like a hot tub's worth of blood being processed every day. And that's really the stakes of what we're talking about today, isn't it? When this machine breaks, it isn't just about bathroom habits. It's catastrophic.
Absolutely catastrophic. The morbidity here is huge. Our source material cites the U.S. renal data system, and they note over 808,000 Americans have end-stage kidney disease, ESRD.
Right.
That's nearly 1 million people whose kidneys have effectively shut down. They require replacement therapy just to stay alive.
And the cost mentioned in the chapter was staggering, too.
Right. Dialysis costs about $72,000 per person annually. And the mortality rate for end-stage renal disease is actually higher than most newly diagnosed cancers. So understanding how the kidney breaks, the underlying pathology, is critical. So
here is our mission for today. For everyone listening, we are treating this deep dive like the last-minute lecture for every medical student, resident, or, just pathology enthusiast tuning in. We are going to decode the pathology of the kidney from the glomerulus all the way down to the tubules. And we're going to do it strictly in the order of the chapter. No outside distractions.
It's a very logical roadmap. We'll start with the clinical syndromes, which gives you the big picture, and then we dive into the glomerular diseases, which I think is usually the hardest part for students to grasp.
Definitely.
Then we hit the tubules, the blood vessels, and finally the congenital cysts and tumors.
So buckle up. Let's unpack the kidney.
Let's do it.
We're starting with section 1, the components and clinical syndromes. The text breaks the kidney down into 4, they call them anatomic pillars. Why is this distinction so important for pathology?
It's important because when you look at a kidney biopsy, or just when you're trying to think through disease mechanisms, you have to systematically evaluate 4 specific targets. You have the glomeruli.
That's your filter.
Right. The tubules, those are the pipes processing the fluid. Then the interstitium, which is the supportive space between the pipes. And finally, the blood vessels.
But here is the thing that I found fascinating, and the text calls it almost like a domino effect. It says it doesn't really matter where the damage starts.
Exactly. This is a massive key concept you need to remember. Anatomic interdependence.
Interdependence.
Yes. If you damage the blood vessels, the glomeruli starve and die. If you damage the tubules, pressure builds up and crushes the glomeruli. So regardless of whether you start with a glomerular disease or a primary vascular disease, they all tend to merge into the exact same endpoint.
Which is end-stage kidneys.
Correct. It basically means fibrosis and scarring, the destruction of all 4 components. The kidney becomes small, it gets firm, and it becomes completely useless.
Okay, before we get into the specific diseases, we have to do a little vocabulary drill for you guys. The text makes a really big distinction between azotemia and uremia. I feel like these get used interchangeably in the hospital all the time, but in pathology, they mean very different things.
They are very different. Azotemia is purely a biochemical sign. It refers to high levels of BUN blood, urea nitrogen, and creatinine in the blood. It means your GFR, your glomerular filtration rate, is dropping. But, and this is the crucial part to understand, you might not actually feel sick yet.
So azotemia is just the lab result. You get the printout, the numbers are high, but the patient might be sitting there in the clinic feeling completely fine.
Exactly. It can be pre-renal, like dehydration, where you just don't have enough blood flow pushing through the filter, or it could be postrenal, like a blockage from a stone. But fundamentally, it's a biochemical finding.
Then what is uremia?
Uremia is when azotemia becomes symptomatic. The word literally translates to urine in the blood.
Yikes.
Yeah, this is when the toxins have built up enough to cause systemic poisoning. The text lists the clinical signs you'll see: pericarditis, gastroenteritis, peripheral neuropathy, and something called uremic frost.
Uremic frost, which I have to say sounds almost beautiful, but I assume from the context it is very much not.
It's deeply unpleasant. It's when urea levels in the sweat are so high that when the sweat evaporates off the patient, it leaves microscopic white crystals of urea on the skin. It's a sign of advanced, untreated, severe kidney failure.
Okay, got it. Azotemia is the number. Uremia is the sickness. Now, the text presents a table 20.3 that lists the big syndromes. We need to clarify these because pretty much everything else we talk about today fits into these buckets. The two big ones to contrast are nephritic and nephrotic.
This is the classic pathology distinction. If you take absolutely nothing else away from this hour, you have to understand the difference between nephritic and nephrotic.
How do you tell students to keep them straight?
Look at the suffixes. Nephritic syndrome, think itis, like arthritis or appendicitis.
Inflammation.
Exactly. This implies inflammation. This is an inflammatory injury specifically to the glomerulus wall. And the absolute hallmark here is hematuria, blood in the urine.
So nephritic equals inflammation equals blood.
Yes. Because the capillary wall is inflamed and reactive, red blood cells actually slip through the cracks. You also get hypertension and mild proteinuria, but the blood is the defining key. Now compare that to nephrotic syndrome.
Good to know.
Right. Think osis, which implies a degeneration or a specific state of being. The glomerular filter isn't inflamed and angry so much as it is broken open to proteins.
The leakers.
The leakers. The hallmark here is massive proteinuria. The text gives us a very hard number you need to memorize: losing more than 3.5 grams of protein per day.
That sounds like a massive amount of protein to just pee away.
It is, and because you're losing all that albumin, and remember, albumin acts like a sponge to keep water inside your blood vessels, the water just leaks out into the surrounding tissues, so you get severe edema, you swell up.
Okay, that's a great heuristic. Nephritic is bloody and inflamed. Nephrotic is leaky and swollen.
Precisely. And then table 20.3 also gives you the time-based syndromes. Acute kidney injury, or AKI, is a rapid loss of functional oliguria or inuria happening in hours to days.
Chronic kidney disease.
CKD is the slow burn, a GFR of less than 60 for at least 3 months.
All right, we have our pillars, we have our syndromes. Now we have to go to the real heart of the matter. Section 2, glomerular diseases. The text calls this the filtration barrier.
The glomerulus is the business end of the kidney. If you're looking at figure 20.1 in the text, it beautifully maps out the structure. It's a tiny ball of capillaries, but the wall of that capillary is highly specialized. It has 3 distinct layers you need to be able to visualize.
Walk us through them.
First, the fenestrated endothelium. The cells lining the blood vessel actually have holes in them, fenestrae, that allow fluid to pass out of the blood.
Like a silker hose.
Exactly. Then wrapping that is the glomerular basement membrane, or GBM. This is a thick meshwork of collagen and glycoproteins. And finally, on the very outside, sitting in the urinary space, you have the podocytes. These are the visceral epithelial cells.
I've always loved the name podocytes, literally foot cells.
It's incredibly descriptive. They have these long tentacles called foot processes that wrap completely around the capillaries. And the processes from adjacent podocytes interlock with each other, kind of like interlacing your fingers or zipping a zipper.
And the spaces between the fingers are the slits.
The filtration slits, yes, covered by a thin slit diaphragm. The text explains that this entire 3-layer barrier filters by size and by charge. The basement membrane has a negative charge, so it repels negatively charged proteins like albumin, but lets water and small solutes through.
So when we talk about glomerular disease, we're really talking about something coming in and breaking this specific barrier.
Yeah.
And the text highlights 2 main ways this happens: immune complexes and podocyte injury.
Right. Let's look at immune complexes first, which is diagrammed in figure 20.6. This is basically antibody-antigen clumps getting stuck in the filter.
Like throwing gum in the gears.
That's a great way to picture it. And the text distinguishes between in situ formation, where the antibodies attack an antigen that is actually planted in the glomerulus, and circulating complexes,
where the clumps form somewhere else in the blood and just happen to get trapped in the renal filter as they pass through.
Exactly. And location matters here so much. The text seems to really care about where that gum gets stuck.
Right, because it changes everything about the disease, doesn't it?
It determines how the disease looks under the microscope and how it acts clinically. You can have deposits that are subepithelial, meaning on the outer side, right under the podocytes.
Okay.
You can have subendothelial deposits on the inner side, under the blood vessel lining. Or you can have mesangial deposits stuck in those structural support cells in the middle of the tuft.
And then there's the other major mechanism, podocyte injury.
This one is structurally simpler but totally devastating. If the podocytes get hurt, say by toxins, cytokines, or certain antibodies, they react by retracting those foot processes. The text calls it effacement.
Effacement. It says they basically flatten out.
And when they flatten out, they lose that complex zipper structure. The slit diaphragm opens up, the charge barrier is lost, and proteins just flood through. And that is the fundamental mechanism of nephrotic syndrome, massive proteinuria.
One thing the text mentions as the ultimate outcome of all this, and this goes back to our domino effect, is that nephron loss leads to hypertrophy of the remaining nephrons, which just leads to maladaptive sclerosis, a vicious cycle.
It is a terrible cycle. If a disease kills half your glomeruli, the remaining half have to work twice as hard to clear the same 1,700 liters of blood.
Right.
They physically enlarge hypertrophy. They manage higher pressures. And that constant hemodynamic stress eventually causes them to scare down too. It's why preventing the progression of chronic kidney disease is so hard. Once that cycle starts, it literally feeds itself.
Okay, let's get specific. We are going to break the diseases down exactly like the book does. First up is section 3. The nephritic spectrum, the inflammatory ones.
So we're looking for the itis, blood in the urine, hypertension, and inflammation. Let's start with the absolute classic, acute proliferative glomerulonephritis, often just called post-infectious GN.
The textbook scenario here is usually a child, right?
Classic board-style case. A child has a strep throat infection or maybe a skin infection like impetigo. They totally recover from the infection, but a few weeks later, they develop malaise, a mild fever, and brown urine.
The text says smoky brown urine. That's the hematuria, right? The blood oxidizing.
Exactly. It's caused by circulating immune complexes from that strep infection finally planting in the glomerulus. The complement cascade gets activated, and neutrophils just swarm the area to attack the complexes.
So if you looked under a light microscope, what would you see?
The morphology is very distinct. The glomeruli are hypercellular. They look huge, swollen, and literally stuffed with proliferating cells and inflammatory leukocytes.
And on electron microscopy. Because there's a very specific finding here that I know is a massive testing favorite.
Subepithelial humps, you have to know that term. These are the dense immune complexes sitting on the outside of the basement membrane, right under the podocytes. They literally look like little Pamel humps sitting on the membrane.
And what's the prognosis for this child?
In kids, it's actually very good. Over 95% recover spontaneously with conservative therapy. But the text does note that in adults, it can be worse, sometimes failing to resolve and progressing to chronic kidney disease.
Okay, moving from a generally good prognosis to a very scary one. Rapidly progressive glomerulonephritis, or RPGN.
The name tells you everything you need to know. It is rapid. You lose renal function in a matter of days or weeks. But the visual hallmark you have to know here is the crescent.
Let's unpack the crescent. What are we actually looking at? Is the glomerulus itself shaped like a moon?
No, the glomerulus is being crushed by a moon.
Okay, what does that mean?
Imagine the glomerulus is a delicate ball of capillaries sitting inside a cup, the Bowman capsule. In RPGN, the glomerular capillary wall violently ruptures. Fibrin and inflammatory factors spill out of the blood and leak into the urinary space of the cup.
And the cup reacts to that.
Violently. This spilled fibrin stimulates the parietal epithelial cells, the cells lining the inside of the cup, to rapidly proliferate. They pile up layer upon layer along with infiltrating macrophages, and they form this massive crescent-shaped cellular mass that physically squeezes and crushes the glomerular tuft until it dies.
Wow, so a crescent is literally the kidney's own capsule collapsing in on the filter.
It is a sign of severe necrotizing injury. If you look at a slide and see crescents, you are in big trouble. Now, the text classifies RPCN into 3 distinct types based on the underlying immune mechanism. This is high-yield differentiation.
What's it, type 1?
Type 1 is anti-GBM disease, also known as Goodpasture syndrome when it affects the lungs too. Here, you have rogue antibodies that directly attack the collagen in the glomerular basement membrane itself.
Situ.
Right. And if you do an immunofluorescence stain, you see a linear pattern. It's a beautifully smooth, continuous glowing line outlining all the capillaries because the antigen is the membrane itself.
Okay, what about type 2?
Type 2 is immune complex mediated. Think of this as a severe complication of another disease, like a massive post-infectious GN or lupus nephritis. The immune complexes clump up, so the immunofluorescence staining is granular or lumpy-bumpy, not smooth. Type 3 is pouchy immune. Pouchy means few or sparse, so on immunofluorescence it's totally dark. There are no immune deposits. This type is usually associated with circulating ANCA antibodies, like in ANCA-associated vasculitis.
Got it. So crescents equals RPGN equals bad news, requiring rapid treatment to save any renal function. Now, let's flip the coin. We're moving to section 4. The nephrotic spectrum. The leakers.
So we are shifting gears completely. The inflammation is mostly gone. Now we are looking for massive protein loss over 3.5 grams a day, hypoalbuminemia, and severe edema. We have 4 big diseases to cover in this bucket.
First up is membranous nephropathy.
This is the most common cause of primary nephrotic syndrome in adults. And recently, science has figured out exactly why it happens. The text identifies the culprit. Most patients have autoantibodies against a specific podocyte antigen called PLA2R, the phospholipase A2 receptor.
And the morphology, what does it look like?
Well, the name gives it away. Membranous. Under the microscope, the capillary wall gets diffusely and uniformly thickened. But the absolute key visual is when you use a silver stain. The text describes spikes.
Spikes? Like actual pointy structures?
On the slide, yes. The immune complexes deposit on the outside of the basement membrane. The kidney tries to cover them up by growing new basement membrane matrix around and between the deposits. So on a silver stain, which only stains the matrix and not the immune clumps, you see these little black spikes protruding up, almost like a tiny picket fence.
Okay, that is a great visual. Thick membrane, spikes on silver stain, primarily in adults. Next up is minimal change disease, or MCD.
This is the counterpart for children. It is by far the most common cause of nephrotic syndrome in kids, especially under the age of 6.
And I'm assuming the name minimal change implies what?
It implies that under a regular light microscope, the kidney looks totally normal. You can't see the problem. A pathologist looks at the H&E slide and says, this kidney looks fine.
So how on earth do you diagnose it?
You have to use an electron microscope. You have to zoom way, way in. And what you see is the diffuse effacement of the foot processes. The podocytes have just completely flattened out across the membrane.
Why does this happen if there's no obvious immune complex?
It's thought to be a cytokine-mediated damage, possibly from T cells, that messes up the complex charge barrier of the slit diaphragm. But the really good news here is the treatment. The text emphasizes that this disease responds dramatically to corticosteroids. Most kids clear up quickly and do very well.
That's a relief.
Yeah.
But then we have the next one, focal segmental glomerulosclerosis, or FSGS, which sounds intimidating.
The name is a mouthful, but if you break it down, it describes the lesion perfectly. Focal means it affects only some of the glomeruli in the kidney, not all of them. Segmental means within a single affected glomerulus, it involves only a part of the capillary tuft, not the whole ball.
And sclerosis implies scarring.
Right. It's a focal, localized scar.
This one seems to have a lot of associations listed in the text.
Yes, it can be a primary idiopathic disease. But importantly, it's heavily associated as a secondary effect of HIV infection, heroin use, sickle cell disease, or even massive obesity. It basically represents a pattern of injury where podocytes die off, the capillary collapses, and it leaves a dense collagen scar.
And how does it compare clinically to minimal change disease?
Poorly. Unlike MCD, FSGS does not typically respond well to steroid therapy. It's a much tougher diagnosis, and a significant portion of these patients progress relentlessly to chronic renal failure.
The last of the big nephrotics is membranoproliferative GN, or MPGN.
This one is actually a bit of a hybrid. It can present as nephrotic or nephritic, but the classic visual hallmark you have to know here is tram tracking.
Like a literal tram track, 2 parallel lines.
Yes. The glomerular basement membrane physically splits. You get a double contour. This is caused by mesangial cells, those support cells proliferating and actually pushing their cytoplasm out into the peripheral capillary wall, splitting the basement membrane in two.
And the associations for MPGN?
Type I is an immune complex disease very heavily associated with chronic infections, specifically hepatitis B and hepatitis C. Type 2, which is now often called dense deposit disease or C3 glomerulopathy, involves a dysregulation of the alternative complement pathway.
All right, that covers the big 4 leakers. But wait, we still have section 5, isolated hematuria and systemic diseases. These are the ones that didn't fit neatly into the major syndrome boxes.
Right. Let's start with IgA nephropathy, which historically was known as Berger disease.
The text calls this the most common primary glomerulonephritis worldwide.
It absolutely is. And the pathogenesis is right in the name. It's caused by abnormally glycosylated IgA antibodies depositing right into the mesangium, that central stalk of the glomerulus. It triggers localized inflammation.
What's the classic patient story you'd see on a board question?
It's usually a child or young adult. They get a mild respiratory infection or maybe a GI bug, and then just a day or two later, bam, gross hematuria, blood in the urine.
Wait, how is that different from the post-trip GN we talked about earlier? That was also an infection followed by blood.
It's all about the timing. Post-strep GN happens weeks after the infection. There's a distinct latency period. IgA nephropathy happens days after, sometimes while they still have the sore throat. We call it synpharyngitic. The viral infection flares up their mucosal IgA production, and that poorly made IgA gets stuck in the kidney almost immediately.
That is a phenomenal clinical pearl. Weeks versus days. Okay, next up in this section is Alport syndrome.
This is a purely genetic disease, usually X-linked. It's a fundamental defect in the genes that make type 5e collagen.
Why is type 5e collagen so important here?
It's the primary structural mesh that makes up the glomerular basement membrane. If your type 5e collagen is faulty, your filter is physically weak. But it's not just in the kidney. Type 5e collagen is also crucial in the ears and the eyes.
So you get systemic issues.
Exactly. The classic clinical triad is kidney failure, progressive nerve deafness, and various eye disorders like lens dislocation.
And the electron microscopy finding.
Figure 20.9 shows it beautifully. It's called a basket weave appearance. The basement membrane isn't a smooth ribbon. It irregularly splits, thickens, and thins out, literally looking like the interwoven strands of a basket.
Fascinating. We also have to mention systemic lupus erythematosus, SLE.
Lupus is the great imitator in pathology, and the kidney is no exception. The text notes it can mimic almost any pattern of GN we've discussed, but the classic severe form class 4 or diffuse proliferative shows what we call wire loop lesions.
Wire loops, what are those?
They are massive, rigid, subendothelial immune complex deposits that thicken the capillary wall so much it looks like a stiff wire under the microscope. Highly active, highly destructive inflammation.
Is briefly diabetic nephropathy.
The text mentions it here because diabetes is a massive cause of secondary glomerular disease and ESRD. The high blood sugar causes non-enzymatic glycosylation of the basement membranes, making them thick and leaky.
And the defining nodule.
Nodular glomerulosclerosis. You get these dense, pink, acellular balls of scar tissue in the mesangium called Kimmel-Steele-Wilson nodules. It's a classic sign of long-term microvascular damage from diabetes.
Okay. Deep breath. We officially survived the glomerulus.
We did. That is undeniably the densest part of the chapter. If you understand those patterns, the humps, the spikes, the crescents, the tram tracks, you understand 70% of renal pathology.
So let's move downstream from the filter, section 6. Tubular and interstitial diseases.
We're moving from the delicate filter to the heavy-duty plumbing and the connective tissue surrounding it. Down here, the main enemies aren't usually complex autoimmune reactions. The enemies are ischemia, toxins, or aggressive infections.
And the first major topic is pyelonephritis, which is infection.
Right. Acute pyelonephritis is a bacterial infection, mostly commonly caused by E. coli, that almost always ascends from the lower urinary tract. It starts as a bladder infection and climbs up the ureters right into the renal, pelvis, and kidney tissue.
What does it look like morphologically?
Well, it's an acute bacterial infection, so think pus. Macroscopically, the text describes seeing little yellow abscesses studded all over the kidney surface. Microscopically, the tubules are completely filled with swarming neutrophils.
And this leads to a very specific finding in the patient's urine, right?
Yes, absolutely diagnostic. White cell casts.
If you see white cell casts, it's pyelo.
Correct, because white blood cells can be in the urine just from a simple bladder infection. But a cast is a cylindrical mold of the renal tubule. If the white cells are packed into a mold, it proves the infection is physically up inside the kidney tubules.
There is also a scary complication mentioned here specifically for diabetics, papillary necrosis.
What is that? The tips of the renal pyramids, the papillae, where the urine empties out, have incredibly poor blood supply to begin with. In a diabetic patient who gets acute pyelonephritis, the inflammation cuts off that tiny blood supply. The tips undergo ischemic necrosis and literally slough off, dropping solid dead tissue into the ureter. It causes sudden obstruction, severe flank pain, and acute renal failure.
Yikes. Okay, what about chronic pyelonephritis?
This is a more insidious long-term process. It's usually due to chronic anatomic issues like vesicoureteral reflux, where a bad valve lets urine wash backward from the bladder constantly, or chronic obstruction from a stone. The kidney slowly gets scarred, deformed, and blunted.
And the unique microscopic finding here, the text calls it thyroidization.
Yeah.
Which the kidney turns into a thyroid.
Not literally, no, but the damaged tubules dilate and get plugged with a dense pink proteinaceous material called tam horsefall protein.
Oh.
Under the microscope, these pink fluid-filled circles look exactly like the colloid follicles of a normal thyroid gland. It's a classic morphological sign of chronic end-stage tubular atrophy.
That is wild. Okay, what about when the tubules get injured, not by bugs, but by drugs?
That's drug-induced interstitial nephritis. This is fundamentally a hypersensitivity reaction. Think of it like an allergic reaction inside the kidney. It happens a couple of weeks after starting certain drugs, classically synthetic penicillins, other antibiotics, or NSAIDs like ibuprofen.
What's the microscopic clue for two?
Eosinophils. If you biopsy the kidney and look at the interstitium and you see a bunch of eosinophils mixed in with the lymphocytes, you should immediately think drug reaction. The patient might also present with a fever, rash, and eosinophils in their urine.
And finally, in this section, the big one for hospital medicine, acute tubular injury, or ATI.
Often still called ATN, acute tubular necrosis in the clinics. This is the single most common cause of acute kidney injury. If a hospitalized patient suddenly stops making urine, this is usually why.
The text lists two main causes.
Right. Ischemia, which means profound lack of blood flow, like a hemorrhagic shock or severe hypotension, or toxins. And toxins can be exogenous, like IV contrast dye, or heavy metals, or endogenous, like huge amounts of myoglobin released from crushed muscle in rhabdomyolysis.
The text explains a really interesting cellular mechanism here regarding cell polarity. I want to dig into this.
This is genuinely fascinating biology. The tubular epithelial cells are highly polarized. They have a distinct top, the apical side touching the urine, and a bottom, the basolateral side touching the blood.
Right.
Normally, the NOC AT-PACE pumps are anchored to the basolateral side, pumping salt into the blood so water follows it. But when these cells get hit by ischemia, their internal cytoskeleton collapses. They lose this polarity. The pumps physically drift around to the apical side.
So they end up on the wrong side of the cell.
Yes. So instead of reabsorbing sodium into the blood, they accidentally pump sodium out into the urine. This triggers a feedback loop called tubulo-glomerular feedback that senses all that sodium, thinks the pressure is too high, and clamps down on the incoming blood vessels, worsening the ischemia.
That is a disastrous design flaw. And eventually the cells just die and fall off.
Yes, the dead and dying cells detach from the basement membrane and pile up, physically clogging the tubule lumen. This debris gets compacted and washes out in the urine as granular casts, often classically described as muddy brown casts.
So muddy brown casts equals ATI.
And clinically, you see a classic three-phase course. First, the initiation phase where the injury happens. Second, the maintenance phase where the tubules are plugged and the patient makes almost no urine oliguria.
And the third phase.
The recovery phase. The tubules start to heal and clear the debris, but the new cells haven't learned how to concentrate urine properly yet. So the patient suddenly makes huge volumes of completely dilute urine polyuria. You have to watch their electrolytes very closely here until full function returns.
Moving on to section 7, vascular diseases. The pipes causing the pressure.
Hypertension is the absolute key player here. The kidney and your systemic blood pressure are locked in a very tight marriage.
Let's distinguish benign versus malignant nephrosclerosis.
Benign nephrosclerosis is what happens to the kidney over decades of poorly controlled, chronic, essential hypertension. The small arteries and arterioles undergo hyaline arteriolosclerosis.
Those means
Plasma proteins leak into the vessel wall, and the wall overproduces matrix. Under the microscope, the vessel walls get thick, pink, and glassy, and the lumen narrows. It chokes off blood flow very slowly.
and the gross appearance of the kidney.
The text calls it grain leather. Because the ischemia is patchy, you get thousands of microscopic scars on the surface, making it look finely granular, like pebbled leather. The whole kidney symmetrically shrinks over time.
Malignant hypertension is completely different, though.
Yes, malignant hypertension is a medical emergency. This is when the blood pressure skyrockets, usually over 200 systolic or 120 diastolic. The vessels don't have time to slowly adapt. They undergo hyperplastic arteriolosclerosis.
And the visual for that.
Onion skinning. Smooth muscle cells in the vessel wall rapidly multiply in concentric rings to try to contain the massive pressure, literally looking like the layers of an onion.
That sounds intense.
It is. And the arterioles can also undergo fibrinoid necrosis. The sheer pressure bursts the vessel wall, it dies, and gets smeared with bright pink fibrin. The kidneys fail rapidly.
We also have thrombotic microangiopathies, TMAs like HUS and TTP.
This is an entirely different mechanism. This is about widespread endothelial injury triggering the platelets to activate. They form microscopic fibrin thrombi in all the capillaries, including the glomeruli. As red blood cells try to squeeze past these clots, they get sliced in half cystocytes. It shreds the blood and clogs the kidney.
And then atheromelic disease. This one always makes me cringe a bit.
It's highly specific. It usually happens iatrogenically after an endovascular procedure. A surgeon snakes a catheter up the aorta, and the tip accidentally scrapes off a piece of an old, fragile atherosclerotic plaque.
And showers of plaque fly into the kidney.
Showers of tiny cholesterol crystals. They lodge in the small renal arteries, triggering a foreign body giant cell reaction that chokes off the vessel.
And under the microscope, what does that look like?
You see cholesterol clefts.
Yeah.
Because the actual lipid cholesterol dissolves away during the chemical processing of the tissue slide, you are left with these distinctive needle-shaped, empty white holes right in the middle of the artery wall.
Incredible. Okay, section 8, congenital and cystic diseases.
Let's talk about polycystic kidney disease, or PKD. These are major causes of renal failure.
Let's do autosomal dominant, ADPKD first.
Yeah.
This is the adult onset form.
Right. The kidneys in ADPKD get absolutely massive. The text says they can weigh up to 4 kilograms. Normal is like 150 grams. That's nearly a 9-pound kidney.
That is just unfathomable. It takes up a whole abdomen.
It really does. The kidney parenchyma is entirely replaced by thousands of expanding fluid-filled cysts. It's caused by inherited mutations in either the PKD1 or PKD2 genes, which encode proteins called polycystin that localize to the primary cilia of tubular cells.
And there is a crucial extrarenal association here that can be deadly.
Yes. Berry aneurysms in the brain, specifically in the circle of Willis.
So if you have ADPKD, you have to worry about a sudden brain hemorrhage.
Correct. A subarachnoid hemorrhage from a ruptured berry aneurysm is a very real risk for these patients. They also get cysts in the liver and mitral valve prolapse.
What about the childhood form? Autosomal recessive PKD, ARPKD.
This one presents right at birth or in infancy. The kidneys are enlarged, but unlike the adult form, the surface is usually smooth. Morphologically, the cysts aren't big spheres, they are microscopic cylindrical dilations of the collecting ducts. On a cross-section, the kidney looks like a fine sponge.
And the liver's involved here too.
Yes, but differently. Almost all these infants have congenital hepatic fibrosis. The liver issues are often what dictates the clinical outcome if they survive the initial renal failure.
And there's one more cystic disease mentioned, nephronophthisis.
It's quite a mouthful. It's a group of medullary cystic diseases. It's actually a very common genetic cause of end-stage renal disease in children and young adults. The key differentiating feature is that the cysts are concentrated specifically at the corticomedullary junction, deep inside the kidney, not all over the cortex.
Finally, we made it to section 9, obstruction and tumors.
The end of the line. Let's start with obstruction, which leads to hydronephrosis.
Which literally translates to water on the kidney.
Basically. If you block the ureter downstream, the urine backs up. The renal pelvis and palaces dilate massively. The high pressure from that backed up urine compresses the delicate renal parenchyma against the tough outer capsule,
causing atrophy.
Exactly. Over time, the entire kidney atrophies into just a thin-walled, useless cystic sac.
And what usually blocks it? Stones. Urolithiasis.
The text lists 4 main types of kidney stones you need to distinguish. First, calcium stones. Mostly calcium oxalate or calcium phosphate. These are by far the most common, accounting for about 70% of all stones.
Okay, what are the others?
Next are struvite stones, made of magnesium ammonium phosphate.
The staghorn calculi.
Right. They get so huge, they take the shape of the entire renal pelvis, looking like deer antlers. These are heavily associated with chronic infections by urea-splitting bacteria, like Proteus. The bacteria make the urine alkaline, which precipitates the stone.
Then you have uric acid stones.
Yes, typically seen in patients with hyperuricemia, like those with gout, or leukemias undergoing chemotherapy. Importantly, uric acid stones are radiolucent. You can't see them on a standard X-ray. And finally, cysteine stones, which are caused by rare genetic defects in amino acid transport.
And to close out the pathology entirely, tumors. Renal cell carcinoma, RCC.
The most common type of renal cell carcinoma is clear cell carcinoma.
And why is it called clear?
Because under the microscope, the cells have abundant, completely clear cytoplasm.
Like they're empty.
Well, they look empty on the slide because in life, they are absolutely packed with lipids and glycogen. When the tissue is washed with solvents to prepare the glass slide, all the fat dissolves away, leaving empty, clear spaces.
And the driving genetics behind this tumor.
It is extremely strongly associated with the loss or mutation of the VHL gene, the von Hippel-Lindau tumor suppressor gene, which is located on chromosome 3. Loss of VHL causes the cells to upregulate factors like VEGF, making the tumor highly vascular.
The classic clinical triad for RCC.
Hematuria, flank pain, and a palpable abdominal mass. But, and the text warns about this specifically, this triad rarely appears altogether until the disease is very far advanced. Today, it's most commonly found incidentally when a patient gets a CT scan for some other completely unrelated reason.
Okay, wow. That was a true marathon. We made it from the very tip of the glomerulus all the way down to the tumors.
It's an incredibly dense chapter, probably one of the densest in the entire Robbins book.
If you had to give the listener one big takeaway, the ultimate so what of the kidney, what is it?
I'd say this. The kidney is an incredibly resilient organ, but it is ultimately vulnerable to a single inescapable endpoint. Whether you clog up the filter with immune complexes, or you kill the tubular workers with ischemia, or you blow out the vascular pikes with hypertension, the kidney's final response to chronic injury is always the exact same: fibrosis.
It just scars down.
It scars down. And once that massive scarring starts and nephrons are lost, it's a self-perpetuating cycle. Protecting the kidney fundamentally means catching these upstream causes, managing the diabetes, lowering the hypertension, treating the lupus long before they can trigger that irreversible downstream avalanche of scarring.
Well put. It makes me wonder, as a final thought for everyone listening, what if future therapies could intervene right at that cellular level? Like, what if we could figure out how to pharmacologically reverse that polarity flip in the tubular cells during acute injury before they die and detach? Or find a way to make podocytes regenerate like other epithelial cells do instead of just scarring over? That would completely change the trajectory of end-stage renal disease.
That is exactly where the frontier of nephrology research is heading right now.
Amazing. Well, with that, we have officially survived the glomerulus.
We did, barely.
Thank you so much for joining us for this deep dive. On behalf of the whole Last Minute Lecture team, thanks for listening. Good luck with your studies. Keep reviewing those slides and keep those kidneys filtering.
And please, stay hydrated.
Catch you next time.